Thanks very much, Chris. That was fantastic. Thanks for the excellent introduction to the problems and limitations in this domain. Context does indeed matter. It's great to think about what the cost function should be rather than just our traditional AUC and AUPRC. So with these in mind, our next speaker is going to talk about how we develop and assess machine learning models. Our next speaker is Dr. Shamim Nemati. He's an assistant professor of biomedical informatics and a director of predictive health analytics at UCSD. He's the lead PI on a multi-center BARDA-funded study, currently involved in the retrospective validation and the prospective implementation and FDA clearance of a machine learning-based sepsis prediction algorithm that was developed as part of his BD2K K01 award, which he undertook in some part as faculty at Emory. I've been privileged to work with Dr. Nemati for over a decade, dating back to our time together at MIT. And I'm delighted that he agreed to join us today to discuss some of the key issues surrounding the construction and the assessment of machine learning algorithms, particularly in the context of sepsis. Thanks for joining us, Shamim, and over to you.
Thank you very much for the kind introduction. I'm very, very much honored to be part of this session. The first couple of slides that I will be talking about is actually in the sort of background of work done by Dr. Clifford earlier in 2010 on constructing the MIMIC database, and then Dr. Saria's work on early prediction of septic shock, and then Chris's work on really translating sepsis tree into a clinical construct that can be implemented in a clinical setting using clinical data. So I have a lot to thank our panel members for my work. Okay, so let me see if I can move on to the next slide. All right. Okay, so around it, 2016 or so, I was working on constructing a pretty large data set at Emory University, including 30,000 ICU patients. And around that time, Chris's paper came out on the sepsis tree definition. So we managed to implement the definition on these 30,000 patients and retrospectively label them for onset time of sepsis and construct a machine learning algorithm that was published in Critical Care Medicine. One of the key features of this algorithm was incorporation of high resolution data, data from bedside monitors, but also we made an attempt to make the algorithm more interpretable by introducing some tools from machine learning that allows us to, for every single prediction, to say what are the top contributing factors to the risk score. I have a little bit of hard time moving this forward. Yes. All right. Okay, moving forward, next slide. We spent the next couple of years essentially building a real-time version of this algorithm at Emory University. I was very fortunate to work with a very talented group of software developers, Dr. Ashish Sharma from Emory, who really said, let's build something that is transportable across institutions. So we built a containerized application that connects to the backside electronic health record, gets the data, massages it, puts it in the right format, and calls the sepsis algorithm, and eventually pushes the scores as well as basic information about the patient to the front-end application. So in building this application, we worked very closely with our tele-ICU nurses following the 5 rights of clinical decision support tools. In particular, the first one being the right information. For us, we wanted to get reliable predictions as well as the explanations for those predictions, in addition to some context to our nurses, which are the right persons. Also, we wanted to use the right CDS interventions. In our case, we decided to go with simple alerts that are shown in the bottom right here. We sorted patients according to the risk for sepsis, and if you click on one of these panels, it would flip over and it would show the top causes for sepsis. So in terms of thinking about making this alerts more actionable, we spent quite a bit of time thinking about what is the right time for making these such alerts. And a number of back and forths with our nurses, we decided to go with 4 to 12 hours in advance. And later on, I get into describing why that was important. Additionally, we wanted to make the predictions prior to clinical recognition and also prior to initiation of treatment, which makes it more clinically useful. So as we were talking about building the user interface, our nurses really emphasized putting an option for so-called snooze. And they wanted to have this option so that as soon as the score goes above the threshold, they have some time to assess the patient for themselves. And this made us really think that, when you implement this type of algorithm, suddenly the algorithm is being deployed in a particular context. There's a clinical protocol. And so when you're evaluating the algorithm, you have to take these type of clinical protocols into account. And that's where we started thinking about this concept of utility of an algorithm rather than just the performance of the algorithm in terms of AUC or positive predictive value. So before getting into that, you guys are all familiar with this concept of AUC, and you know that for prediction of sepsis, you would need to look at things like area under precision recall curve. But something that is less appreciated, I believe, is this notion that sepsis algorithms, they get evaluated under different evaluation protocols. So I'm just listing 3 of them over here. The first one is so-called the infinite horizon prediction, where at some point during patient's stay, you have access to some measurements, and you are making a prediction into the future. This prediction could be 24 hours or 34 hours, or it could be a week in advance. The second one is this look-back approach that you assume that you know the time of sepsis. You go back for 6 hours, and then you use the measurement at that point to make a prediction. You do the similar thing for the control group. You select a random point in time, and you say, if I use the data at that time point, how will I do in saying that this patient doesn't have sepsis? An alternative approach, which is the sequential approach, you start from the beginning of a patient's record. You make a prediction over a, let's say, 4 to 6 hours window. And if there is no septic event within that window, you call it a sensor event. And then you move your window by 1 hour or so, and you make another prediction until finally you arrive at the time of sepsis. So it turns out, depending on what type of evaluation protocols you have, and there are quite a number of them. There's a case control one that is being used in biomarkers. There's a max value one that essentially says, I'm going to look back from the time of sepsis and I'm going to use the maximum value of the score. Or the one-shot approach that you say, I'm going to make a prediction only at the time of suspicion of infection or at the time of admission to, let's say, emergency department. Depending on which of these approaches you use, you end up with very different prevalences of positive label in your data set. So let's say if you are looking inside the ICU and the prevalence of positive label is 25%, it turns out in the first 2 approaches, you have 25% positive labels versus in the last approach, you end up with only 2%. Because for a patient who eventually gets sepsis, most of their initial windows are going to be non-septic. So it really raises the question that can we compare AUCs across all of these different methods? And the answer is really, it's very difficult. No, your AUCs, PPVs are going to be different. In particular, your PPVs that depends on prevalence. Furthermore, as I mentioned earlier, when you implement these algorithms, you attach certain clinical protocols. So the first time you cross a threshold, maybe the nurse will put the algorithm on a snooze for the next 6 hours to evaluate the patient. There are other nuanced issues, such as if I'm making prediction for sepsis, let's say, again, 6 hours ahead prediction, what happens if the score goes above the threshold, 7 hours or 12 hours before that? Is that a false alarm or is it a true alarm? It really depends on how you construct your performance metrics. So that's why we started thinking about the concept of utility, which is really concerned with clinical protocols under which the model is evaluated. So when we got to organizing the FISNet Challenge 2019 for early prediction of sepsis, we sat down and we came up with this idea of a utility function that rewards early prediction up to 6 hours more than late prediction and also predictions that are, let's say, 24 hours early. So if the time of sepsis, which we use the sepsis tree construct to tag our patients, if the time of sepsis is over here and you are at 6 hours before that, that's the time of optimal prediction of sepsis. But also if you are at least a couple of hours late, we give you a point. And the reason for that was because of the sepsis tree or SEP1 bundle that says, within 3 hours of recognition of sepsis, you have to put patients on antibiotics or their blood cultures, et cetera, et cetera. And so even if you miss the first hour, on the second hour, there's still, some points that you get according to this utility function. Similarly, for the false negatives, the more you miss the time point of interest, you start to accumulate more negative utilities. And as you think about the false positives and true negatives, we decided to assign a certain negative utility to false positives. But this really depends on the tolerance of the end user for false positives. If you are at the bedside, you may have lower tolerance. If you are operating in the context of a tele-ICU, you may have a slightly higher tolerance. But really, this was an attempt to put the sort of performance metric in a more clinical context and look in the context of a protocol. So moving forward, we have been thinking through prospective evaluation methods. The first one is being the multi-reader, multi-case study in which you select a number of cases and you present it to multiple readers, and then you see if really giving the tool to the clinician is going to change their decision-making in terms of early recognition of sepsis or management of sepsis. Then, ultimately our goal is to get into, first single center clinical trials and then multi-center clinical trials. But it seems like there's an intermediate step that might be somewhat a low-hanging fruit, which are the quality improvement studies in hospitals. So most modern hospitals are spending a lot of efforts in quality improvements. They have a chief quality improvement officer. They have quality improvement committees. And many of these committees are really concerned with things like SEP1 bundle compliance, looking at mortality, OE ratio, or looking at the hospital ranking. And I wanted to bring attention to, some of the factors that are incentivizing hospitals to make changes into their workflows. In particular, we started looking at this OE ratio, which is a ratio observed to expected mortality. And this expected mortality component is something that comes from typically a regression model that says, how sick are your patients? So if I'm looking at how many deaths we have in a given hospital, I'm going to adjust it by, how sick are the patients that are being seen in this hospital. And in a typical hospital, you might see something like in this figure, over a period of 5 to 6 years, they're tracking this OE ratio. And whenever the numbers goes up, it's a cause of concern. Whenever the number goes down, hospitals, they celebrate. And ultimately, some of these OE ratios, they might affect their hospital ranking. So, looking into implementing these algorithms and seeing what kind of effect they have on OE ratios, that might be of very much interest to hospitals. Just very briefly, I recently started looking at this OE ratio. And as I mentioned to you, the E part comes from a model. And these models are developed by different companies that implement them in many, many different hospitals, and they use the model to assess what the expected mortality for a given quarter for this particular patient population is. So we were working on an algorithm for early prediction of shock in ED, and we were trying to think through what kind of effect it might have on the OE ratio. Soon we realized that shock itself is a variable that goes into the algorithm. And we asked the question, what do they really mean by this shock? And it turns out this is a shock that occurs from the time of admission until the midnight for that patient. So if you get admitted to the hospital, let's say at 2 p.m., whatever happens until the midnight is considered a pre-existing element and goes to the shock, which again shows up in the denominator here. Similarly, if you are admitted at 9 p.m., whatever happens for the next 3 hours. So paradoxically, it turns out if you predict shock early and you can avoid it, the hospital might get penalized. And this was very unintuitive to us. So, I'm happy to discuss this more as a part of the panel, but it's showing that really some of the quality metrics that are being used in hospitals nowadays may not be very congruent with some of the works that machine learning people are doing. And in my next slide, I want to emphasize that it's important to develop metrics for assessing performance of machine learning algorithms that take into account care protocols, care mix complexity, cost, quality measures, and even things like ranking of hospitals and what are the factors that goes into those. Because if we succeed in doing that, then it's a lot more likely for hospitals to want to implement these algorithms and use them in practice. So things like, does this algorithm make me more compliant with SEP1 bundle? Does this algorithm help me to reduce costs within a given MSDRJ category? These are important questions. And as I spend more time in hospitals, I started to realize that there's a lot of buzz, a lot of AI, but most of the actions are happening on the quality improvement side. And it's very important for machine learning people to start interacting with QI people and really looking deeply at the techniques that they are using, at the quality metrics that they are using, and how their algorithms can help with improving quality. In fact, probably one of the most impactful changes in the past decade has been introduction of this sort of smart critical care notes, with sepsis being one of the first item on the drop-down menu. It turns out just introduction of this drop-down menu increased sepsis diagnosis in hospitals by quite a lot. So I'm not a fan of vampire movies, but I found this meme. Aeon says, Estefan gets all the action. Estefan responds back, says, I cry all the time. And you know how hard it is to cry in every single episode. And that's exactly what my QI friend says. They say, do you know how hard it is to change a menu item in Epic? So with that, here are my acknowledgements, and I'm looking forward to the panel discussion.